Hi, everyone. I'm Rochelle Rosen. I'm one of the faculty in the CTR's Biostatistics, Epidemiology, and Research Design Core, and I'm here to welcome you to the second in our three-part Advance-CTR Qualitative Methods seminar series. Today, we're going to hear from Alex Collins. She's going to talk to us about rapid ethnography. As we begin, just a reminder that for the first hour, we're in a webinar, so we cannot see or hear the participants. Alex is going to speak for about 45 minutes, and then we'll have a chance to answer your questions. You can put your questions in the chat, and I'm going to get them to Alex. At 12 o'clock, we're going to shift to a more open format where those who stay on with us will be able to use their camera and audio to join us in a discussion. And I'm going to let you know when we make that transition. So to get started today, I want to introduce Alex Collins. Alex is a postdoctoral research assistant in the Department of Epidemiology at Brown. She's also a qualitative methods consultant for the Rhode Island COBRI on opioids and overdose. She's a medical social scientist who's been at Brown just a little over a year after completing her PhD work in Vancouver, British Columbia. Alex, please introduce us to rapid ethnography. I'm so glad you're here.
Thanks so much. And thanks everyone who is making time to join this call. Ethnography is something I'm incredibly passionate about, so I'm excited to get to talk with you all a little bit about it today and just kind of get your feet wet in what ethnography is and specifically rapid ethnography. And many thanks to Advance-CTR and Rochelle for inviting me to speak with you all. So as Rochelle noted, I am a trained ethnographer and medical social scientist. I've been doing ethnography for about 7 or so years, starting with my master's work, which was located in Freetown, Sierra Leone. And since then, I've done ethnography predominantly in Vancouver, British Columbia, which is the westernmost province, a city in the westernmost province in Canada, and now undertaking ethnographic work in Rhode Island. My research really lies at the intersection of substance use, harm reduction, access to services, and housing. So this is really the lens through which I'll be speaking mostly about my experiences. So do kind of keep that in mind in case any of those topics may or may not be triggering. There will be some photographs of spaces related to drug use. So if any of that is not kind of for you, do feel free to kind of jump off at that time. So there will be some kind of time at the end to talk about questions, but yeah, I'm ready to kind of introduce you. Before we start, I do want to just pause for a moment and acknowledge that the land that I'm currently situated on, and probably most of you, is the unceded and traditional lands of the Narragansett people. And the Narragansett people, along with enslaved African populations, were also part of the group that built the campus that I also conduct my work on. So we just need to acknowledge this kind of ongoing legacy of colonialism and slavery as we kind of undertake our work in this space. And I have no disclosures. So just kind of a brief agenda for this talk's going to go. I'm going to first do a kind of brief overview of ethnography, just kind of introducing you to this research approach. Then I'm going to talk about ethnography specifically in relation to public health, moving us into rapid ethnography. It's kind of the subsection of ethnographic work in general. And then talk about how you can integrate these types of methods within public health research. So using the example of some of the work I've done myself, and then talking about how you might integrate this into grants if it's something that you're interested in. So I'm not going to give us this very deep, long history of ethnography, but it is rooted in anthropological and sociological kind of fields. And at its heart, it really means writing culture. And it's this focus on cultural understanding. And it really involves, this immersion into people's lived realities. And in doing that, its kind of main goal is to both understand and describe everyday practices that are occurring, social processes and social phenomena that are occurring within natural settings. So rather than having this controlled environment that the research is happening in, like a lab or an office, you as the ethnographer go to where the folks are, you go to where your participants are, and you understand or seek to understand kind of their day-to-day lives. And in doing so, ethnography is quite helpful in clarifying relationships between these broader systems of power and the individual, and what those systems of power look like in people's daily social lives. And it's also important because it helps us understand how people make meaning of their lives within these various contexts. There are kind of two streams of ethnography. The first is this realist approach. This is very much kind of old school, traditional ethnography. It was kind of rooted in research looking at kinships and kind of kinship processes, but it takes more of an objective stance. So the ethnographer is still present, but written in the third person, with this assumption that the ethnographer can be somewhat separate from the participants. So it presents this objective account of information, and it really kind of views the ethnographer as not having an impact on their participants while in the field. And you can compare that to the secondary stream, which is critical ethnography. And this is the school that I was very much raised in. And critical ethnography is much more value-laden and advocacy-based. Its kind of main goal is to foster social change and responds to these social conditions of inequality, specifically of trying to understand and document how these conditions of inequality impact folks kind of in their daily lives. And so kind of in this realm, you work to empower folks in a particular setting. So, voicing the concerns of particular communities, or, having work that challenges the status quo. And so it's really kind of in tune with interrogating power structures and kind of these systemic inequities while in the field. So that's really kind of the perspective that I bring when I do ethnography, is this kind of advocacy-based approach. But what does this look like in practice? How do you do ethnography? And kind of the main feature is that an ethnographer participates in people's daily lives. And this can happen either overtly or covertly. There's this body of research that you can explore to learn more about kind of the ethics around doing covert ethnography. I participate in overt approaches, so people know who I am when I enter the field. I introduce myself as a researcher. They very much are aware that I am there doing research, and so it's nothing hidden per se. And so within this, it's traditionally a single kind of lone ethnographer goes to a field for an extended amount of time, like years. It's definitely not uncommon for doctoral students to spend 2 years kind of at their field site doing data collection. And within that, it's the ethnographer who's actually the primary instrument of data collection. And that data is collected through fieldwork. It's kind of our key tool. And fieldwork is, again, this immersion. You're in a field site, which could be anything from a hospital to a neighborhood, to multiple sites, depending on how your kind of data, what your findings kind of start becoming. And in those spaces, you have informal conversations with people. You document interactions or things that you're observing. Over time, you participate in daily activities, and you have this ongoing reflection. So all of that is data that's being produced. And it's nice because this type of work provides you with a thick description. So you're not just describing events or describing behaviors or practices as if they exist in a vacuum, but you're adding this broader context. You're situating those observations within these larger social and structural contexts that shape people's behaviors and shape kind of our daily lives and perspectives. And a really important piece, and I can't stress this enough, is contextualizing those findings. So again, ethnography, it very much provides you with a close encounter. You're often with, small groups or with individuals in the field, and it's really important to contextualize what you're seeing within these larger systems of power. Because if we remove the actions from kind of their context, we risk reinforcing harm or reinforcing stigma and discrimination of particular populations. For example, my work, again, it was focused a lot around drug use and overdose risk. And so there were many times I was with participants during field work, and we were in back alleys, and I sat with them as they were prepping to use, and sometimes, using with a syringe that they found in the alley. Now, if I only present that without any context, that creates a lot of harm. It points at the individual, and it blames the individual for, particular health outcomes or risk. But if I situate that into why that was happening, socioeconomic marginalization, the role of gender in using drugs, violence that had occurred with this person and her partner and this need to hide it, criminalization, her ethnicity and race had a big impact. All of these things are really important to help us understand that process and how a participant made meaning of these processes. So having conversations with participants is really important for contextualization, as well as triangulating your fieldwork data with other forms of data collection, like surveys or qualitative interviews. And I think, this piece is important for doing engaged ethnography. You don't want to just collect data for the sake of collecting data. And depending on what your topic is, you might be bearing witness to a lot of injustices. And so you have to have this, ability to have ongoing reflection throughout kind of your data collection and throughout your research of what you're seeing, but also having this systematic and deliberate reflection of the self, of yourself, and what it means to be there and to be in the field. And I think, we all come to our research with particular biases that are based on our social location. So things like our gender, our sexuality, our age, our geographic context, and also experiences that we've had. And those very much impact kind of you as an ethnographer in the field. And you have to continue to think about that positionality and how it shapes the questions you ask, who you're talking to and who you're not talking to, and how you are interpreting things. So it is a kind of a time-intensive process to do it well, but it's a really critical piece. And then also having this ethical reflection of what does your presence in the field mean for certain populations. I've been with a participant and my presence meant that they couldn't access a space to use drugs in an observed way, which could minimize their overdose risk. And that was very much because I was there. And I have to wrestle with that is how does my presence maybe inflict more harm for folks that I'm trying to kind of support through this research. So this is, it's not a one-time thing, but it's definitely this ongoing process. So in terms of kind of the role of ethnography in public health, I've talked about kinship and I've talked about, some of the work I've done, but how can this type of approach be impactful for public health and our understandings of public health? And I think, no matter how well-intentioned, public health interventions and messaging often focus on an individual or an individual behavior change as kind of this goal. And in doing so, we often overlook, again, that those realities and those behaviors are situated within these bigger contexts. So things like the social, physical, political, economic factors that are shaping people's practices, they also construct health risk and impact susceptibility of harm. And so we need to really understand those factors as they play out in people's daily lives. We often in public health draw off quantitative forms of data as well, which can leave gaps in our understandings of needs. If we have this kind of population understanding, but we don't look at what's happening on the ground. And so this really kind of turns attention to the need of multiple forms of data that work in tandem to provide us with a more robust understanding of public health interventions and what's needed for whom and how that should look. So I want to take a minute and talk about kind of a really lovely example of what happens when we implement public health interventions based off one type of data. And so this is a bit dated. It's from 2000. I do highly recommend reading it if ethnography is something that's kind of interesting to you. Just bear in mind that there is some language that is kind of related to drug use that is not okay, but just keep that in mind with it being published in 2000. But this article really kind of highlights how our interventions, to really reduce risk, they have to be contextualized. We have to understand how people are interacting with them and kind of what these processes look like as people navigate their daily lives. So this article highlights, in the 90s, there were two cohort studies that were undertaken in Vancouver, Canada, and in Montreal, Canada. These cohorts looked at kind of HIV risk and risk behaviors amongst folks who inject drugs. And as this data was being collected, it turned out that there was a significant association between accessing needle exchange programs and HIV seroconversion. And as you might think about that, it's pretty counterintuitive. Needle exchange programs are implemented to reduce risk of HIV or hepatitis C infection, yet these cohorts were showing that, in fact, the people who were using them more are more likely to seroconvert. So, what that meant was people in the United States took that and ran with it to stymie efforts to implement these, public health interventions. So they took this and said, actually, we don't need needle exchange programs. They can, in fact, create more harm and more risk, and these aren't useful. But in Canada, they took a bit of a different approach. And so they used this to see that, we have gaps in our epidemiological data. Our data is only as good as what we're asking. So we need to just understand why that, it just doesn't make sense. So this first author, Philippe Bourgois, he's a very well-known kind of drug use ethnographer. He undertook rapid ethnography around a needle exchange program in Montreal. So he went for, it was a total of 2 or 3 months, kind of in different chunks, and he observed what was happening around there. And through that observation, he was able to better kind of understand why there might be more HIV risk. And that's based on kind of the social dynamics of cocaine injection in that space. So it was a lot of kind of communal use. It was related to socioeconomic marginalization of people. It was related to the hours of operation. So kind of the time that the needle exchange was open was much more conducive to people who were injecting cocaine, to the caps on how many syringes you could get at a time. So all these kind of structural level and social level factors that work together in a way that did create some risk. And so by understanding that, they were able to better adapt the needle exchange programs. So they were better and more tailored to the population that was accessing them. So this is really just kind of a way to grasp, how ethnography can provide us with some additional data, and how that data is really important for us to iterate on public health interventions and public health messaging, so we can actually reduce that risk of harm for people. So I touched briefly or mentioned it briefly kind of in this last example about rapid ethnography. And so, we don't always have time to spend years in the fields. We don't have time to, always to go and kind of do this back and forth into the field for, sometimes a decade. And that's often when we're looking at public health emergencies. And so rapid ethnography is a way to still provide that context-rich data, but do so in a more kind of condensed time frame that's appropriate for public health and public health emergencies in particular. So there is quite a bit of overlap between ethnography and rapid ethnography, but some key features are that rapid ethnography is very applied. It's highly focused, and the idea is that the data that you collect is going to inform public health interventions. So you do that by harnessing a researcher's familiarity with a setting. You already know kind of these broader contexts that are shaping, say, a neighborhood or shaping a hospital dynamic. You have those connections to people in that setting. So it enables you to do this rich form of data collection, but in a rapid time frame. And there's no kind of one-set way of what that time frame looks like. It can be a week, it can be a month, it can be a couple months, but it is much shorter than a year or multiple years. And it's also useful to promote community engagement because it is applied and because it's done in this need to understand what's happening in a public health emergency on the ground. It's really useful to use it alongside community-based and community-engaged research approaches. And so again, you go into a field, it's still very much robust, it's still theoretically informed, but you're just collecting and quickly disseminating that information rather than sitting on it, and waiting for a paper to come out, which can, as we all know, can take quite a bit of time. And so in terms of why we might use this, it's, and specifically why we use this in terms of, in relation to public health, it's pretty responsive to community needs and contexts. So if we think about, things like how are communities managing a specific health crisis, it's gets us into people's daily lives. It gets us talking to folks and to understand, how are they, what are they doing? How is the community responding? So for example, if we think about the Ebola crisis, this type of, research approach was used quite a lot in West Africa during the Ebola crisis. And it helped them understand, what were the funeral practices people were engaging in and how did that, maybe impact spread of Ebola, or what kind of innovative ways were communities, taking up, or kind of innovative methods communities were taking up to spread the word. Was it through song? Was it through, images and kind of murals? So it really understands, what's happening on the ground. This type of approach can also help address unintended consequences of fragmented public health messaging. So, as we start learning more and more about public health crisis, we share more and more of that messaging. Just like right now, what we know about COVID was very different than what we knew a year ago. So having this kind of incremental release of information can lead to some misconceptions and shake people's trust during public health crises. And so, rapid ethnography can help us understand, who are people trusting? What are people believing? And what might be a better method of communication to get that across? In Vancouver, a big kind of misconception or perception in the neighborhood I worked in was that fentanyl had been purposefully introduced. It was a way for the city to get rid of folks that they didn't want, that were, making gentrification hard for them. And so this was a very common kind of idea that was prominent in the neighborhood. And so if we send public health messaging through the city, it's probably not going to be taken at face value by folks. But who are they trusting? They're trusting, nonprofits, or they're trusting some of the users unions that were in the neighborhood. And so using kind of that understanding to figure out how we can get, public health messages out is a really important thing. Additionally, rapid ethnography helps uncover the disproportionate ways people are impacted. People don't experience public health crises in a homogeneous way. And so this helps us get, again, this on the ground knowledge that again is situated within these larger kind of systems of power that impact, what the population's unique needs are, and that can be used to tailor interventions, be it how it's implemented, or the location it's implemented, or the language used, and all of that's really important for more comprehensively addressing and reducing harm, or addressing risk and reducing harm for people. So I want to kind of give a little bit of an example of what this can look like in practice. And so I'm going to talk about a project that I was involved in Vancouver. We had a kind of a large grant to evaluate various responses to the overdose crisis in Vancouver in particular. Between 2015 and 2016, our province of British Columbia experienced a significant rise in fatal overdoses attributed to fentanyl and related analogs. And so it's kind of at that junction that the province declared the overdose crisis a public health emergency in April of 2016. And that was really important because it kind of opened the door for innovative approaches to addressing this crisis to kind of take hold. And so a lot of these innovative approaches were implemented in Vancouver. And so, it was everything from overdose prevention sites, which are these low threshold consumption sites. People could go and use pre-obtained drugs while being monitored in case of an overdose. There was also drug checking mechanisms, so checking for fentanyl through test strips or through this spectrometer. We also had expanded medications for opioid use disorder and kind of safe supply initiatives. So prescribing Dilaudid, for example, and kind of piloting that intervention. So this study really kind of looked at a range of these strategies and wanted to evaluate, one, how they were implemented and how effective they were and what gaps they might fill in relation to what else was offered or available at the time. And so this study was led by Dr. Ryan McNeil, who was one of my doctoral supervisors. And, it was a great way to use rapid ethnography within an incredibly severe time in the neighborhood. I'm gonna focus just on overdose prevention sites for this part, just as a heads up. So our field site was the downtown Eastside neighborhood in Vancouver. So it's this area on the map highlighted in red. And it's about a 10-block area. It's home to a very large street-based drug scene. It's also a neighborhood that faces an incredible amount of socioeconomic marginalization. And it's being rapidly gentrified by, kind of these young professionals. And so there's a dearth of housing. There's, people are getting pushed out, but it's also the epicenter of the overdose crisis in Canada. It's been one of the most impacted neighborhoods in Canada since 2016. But importantly, this neighborhood also has a very long-standing history of community activism led by folks who use drugs. And so when the overdose crisis hit, a big issue is that folks in the community didn't feel like the city or the province was doing enough. They weren't acting quick enough to save people's lives. So folks in the community took that and responded with opening overdose prevention sites. So this top picture on the left is kind of the first overdose prevention site opened. So again, these are low threshold, meaning it's pretty accessible. There's, you're not filling out a ton of forms. This was, as you can see, literally a pop-up tent with tables and chairs. And it was located right next to a street vending market that was very well populated and had experienced a lot of overdoses nearby. And so this was led directly by kind of community initiatives. And so we wanted to understand, how did that kind of community-driven approach impact accessibility and experiences for people using the site? So these are kind of some of the spaces that we spent a lot of time in. So from December 2016 to April 2017, a team of us undertook over 180 hours of field work in and around overdose prevention sites in the downtown Eastside, and interviewed 72 folks who used drugs that were recruited from these sites as well. And just to kind of pause for a minute and talk about kind of what it's like, what that field work was like, you know, this is part of that kind of ethical reflection that's important. You know, we were in spaces that were designed specifically to save people's lives. So you had to stay out of the way. You know, these are places where people were overdosing. And so you needed to stand back. You can't get in the middle of it. You can see this tent area, it's not particularly large. So, you know, making sure that you aren't ever getting in the way. I mean, if it was really busy, making sure that, you know, you just leave and maybe you come back another time was really important, because there were, you know, there were many times in these spaces that overdoses were happening quite often. And so you just want to make sure that you're not preventing help from coming. I will say this picture on the bottom left, it's after several iterations, the tent is now this kind of indoor space. And so this one has a little bit more room. You know, you can kind of stand outside of, come in the room rather than standing in the doorway. And so this was a space to just watch. And some of these sites had kind of chill areas people could hang out in after, and that was a way you could kind of chit chat with folks. The picture on the right is a women's only space. So I spent more time in this area, and, you know, I would often sit at this table that's pictured. There was a peer worker that would work at the kind of the table against the wall. I could chit chat with whomever was working, talk to the women as they used this site, and just get a sense of, you know, how people felt there. This site was much more kind of relaxed. It was kind of at the periphery of the neighborhood. So, and again, it's only women, it's a women's only site. So it was a little bit kind of a more relaxed feel. It felt a little bit more like a living room than some of these other sites. So this is kind of where we spend a lot of time, is within these spaces, and also the alleyways that were kind of adjacent to these spaces. And in those, there was a lot of observation, and when appropriate, some informal conversations occurred with the staff, with people accessing the space, with people kind of in the alleyways, and just talking about, you know, what was happening and how they felt about these interventions. And from there, again, doing in-depth interviews with people at our field site, which was located a couple blocks away. So there were about 5 of us, 5 ethnographers involved. So again, the PI and another more senior researcher, and then myself and 2 other students. And then we also worked with 2 peer research associates. So these were folks that were from the neighborhood or had lived in the neighborhood for decades, and they had a history of using drugs or currently use drugs. So they were very much aware and attuned to kind of these dynamics in the neighborhood, and they had a lot of trust. People really trusted them. They were very well-known folks, and because they had been there so long, it was really helpful in helping folks like me, who, you know, I hadn't lived in the neighborhood for decades, gain entry into some spaces. And we also, this was a community engaged project. So our community partners involved harm reduction organizations, including ones that helped run some of these overdose prevention sites, sex worker-led organizations, and organizations led by people who use drugs. And so this was a rapid ethnography. And we were able to do that because all of us had experiences and a vast knowledge of this neighborhood. Again, our field office where we worked and did all of our kind of interviews was located just a couple blocks east of where this picture is taken. And we were also embedded in this larger kind of community-based qualitative program of research program. So we had these existing partnerships. The PI had worked with some of these organizations, again, for like over a decade, as well as the other kind of senior level researcher. She kind of grew up working alongside her mom and with a lot of these organizations. So we were really able to harness that experience, and that allowed us to do this more kind of deep dive and quick collection of data. So all of us conducted observations, all of us wrote field notes, and then we talked about this in weekly meetings about what we were seeing, what our perceptions were, what some preliminary findings were. We also all took part in the analysis, and that was really helpful because each of us, again, brings a different lens to the work. Each of us have different experiences that shape how we view kind of our setting, shapes who we're talking to, and kind of our understanding of these processes. So it was really helpful to undertake this collaborative approach to get, again, a lot of data that was really rich in a short amount of time. And that data was able to then get fed back to these organizations in somewhat real time to shape hours of operation and kind of some structural level processes. A really kind of great thing about fieldwork and ethnography in general is that new questions often emerge. This is a very kind of exploratory approach. And so as we were doing this and as we were doing the interviews, a lot started coming up about the role of police. And so we needed to understand, how are police impacting people's ability to access these overdose prevention sites? So myself and two of the peer researchers, we undertook a targeted kind of fieldwork approach over the course of 1 month. So we did varying days of the week and different times of day to try to see what was happening on the ground. And so this was in and around 5 overdose prevention sites in our field setting. And we used observation sheets. So it captured things like where street lights were placed, or how many ambulances we saw, or how many cop cars we saw, more of this environmental scan type approach. We also had informal conversations with people. And again, each of us took field notes. And after kind of our time in the setting, our kind of field session, we would then all go back to the office and do a debrief and talk about things that we saw. Depending on the time of day, sometimes we kind of each went out and did separate sites. But if it was in the evening, we often stayed together. Again, this was largely related to me. I present very young. I'm also not, part of the neighborhood. So, and I'm a woman. So kind of hanging out in some of these alleys wasn't always safe in a drug scene that's marked by quite a lot of gender-based violence. So we did this together, and then we would talk about what we saw. And that went on to, have a separate analysis, but it was embedded in kind of our understanding of what people were saying was problematic in relation to this, the ways that cops were kind of interacting around these sites. And so just to kind of highlight what some of our outcomes were from this work, we were able to highlight the gender dynamics that were present in some of these services. So everything from who worked there to how women accessing the space experienced being there. We were able to document barriers and facilitators to service access. So again, things like the police or hours of operation. And that led to kind of these extended times that they were open kind of as social assistance checks were distributed, because we were seeing large spikes in overdoses around that time, but hours of operation hadn't been extended. So it really helped kind of understand this need to lengthen the time that these sites were open. It was also really useful for demonstrating the gaps that these interventions, these low threshold interventions, were able to fill in relation to existing services that were a little bit more medicalized or had, they weren't quite as comfortable. It wasn't peer workers, but maybe nurses. And so what that dynamic meant for folks who had experienced stigma in healthcare settings. We were also able to illustrate the critical role of peer workers in overdose response. So again, creating a sense of safety or comfort for people, but also highlighting the need for bolstered supports, both financially and kind of mental health supports for peer workers in these spaces, because they were in incredibly traumatic environments. And then this work has also been used in efforts to decriminalize personal drug possession in the neighborhood. So again, that work kind of around policing and how police would kind of hang out near the entrances and would mean that people couldn't access these life-saving services. So all of that has been a really important, addition that this work was able to make while bolstering work and interventions that came out of the community. So again, it's this kind of critical, engaged approach to rapid ethnography. And it was we were able to use kind of community-based approaches and kind of raise up the voices of folks that were really kind of leading the charge in the neighborhood when they felt like the government hadn't acted in a quick enough way. So, how might you do this in your own research? If this is something you're interested in, how could you integrate rapid ethnography into your research design? And so I think, rapid ethnography as an approach is really well suited to understand specific behaviors or contexts or beliefs or systems of power, or mechanisms of resistance among a particular group. So maybe you want to understand the experiences of unhoused veterans. Or maybe you want to understand, how women who have survived kind of breast cancer have experienced the clinic. Whatever kind of your particular group is, understanding kind of these on the ground realities and how, this is a really kind of helpful approach. It's also helpful for addressing urgent situations like public health crises. So, from HIV outbreaks, like very localized HIV outbreaks, like what we're seeing in Boston, or again, COVID, just how are people handling COVID? What are they doing? This is kind of a really helpful approach in doing so. But how do we integrate this? So I think kind of a first step is considering what your time frame is for the grant and who your project team is. Do you have a grant that is a 6-month grant or a 2-year grant? And who on the team, knows the group or has experience or existing knowledge of a particular group or setting? And identifying who that group of interest is with a common culture. And again, does that map on to kind of who your team is comprised of? So would you have that kind of knowledge to kind of come in and do this targeted approach to research? You also need to identify who the gatekeepers are. Who are the kind of key players that can help introduce you to other folks or who know a lot about this particular site or topic? Do you already know them? Can they help you kind of gain entry into this space? Or is this something that, you'd have to learn? You'd have to kind of get to know people because those relationships take time. Also kind of consider your anticipated field site or sites. Do you already have access to those spaces? Is that something that, again, would take time to gain trust and to be able to access? And how much knowledge do you already have about those settings? So not only kind of the day-to-day knowledge of kind of what happens in these settings, but do you know kind of the larger context it's situated in? Like, do you know kind of from the political side what's happening? Or, if gentrification is happening, do you know how people are feeling about that? What do you already know, and kind of what are the gaps in that knowledge that might hinder you from being able to do kind of this rapid approach? And then very importantly, you do have to obtain IRB approval before entering the field. This is still, human subjects research, still, need this kind of ethical approval and okay before you engage in any of this work. Just kind of quickly, some things to consider in terms of IRB applications. You got to think about the methods that you're going to use. So are you going to do observations and interviews, focus groups? What are the kind of range of methods you're using? Additionally, like, who is the community and what is the field site? Being pretty explicit. And again, you're not always going to know what each field site is because, again, things emerge during the course of data collection. But in general, maybe you have a sense of what these field sites are likely to be. And what will be observed during fieldwork? Are you observing people using drugs? Are you observing clinical practices? Giving the IRB a sense of where you're going to be and what you're likely going to be seeing is really important. Informed consent, not only what that looks like if you're doing interviews or focus groups or surveys, but what does it look like during field work? What does it look like if you're with an individual or if you're with a group during field work? What happens if someone says no? Do you walk away? Do you just not talk to that one person? What does that process look like? And is it ongoing? Because again, sometimes you're going to your field sites on multiple occasions. So if you're interacting with the same people, are you giving them an opportunity to withdraw at some point? What does that whole kind of consent process look like? And how will you maintain confidentiality in field notes? So I think this is really important, especially if you're kind of doing work around things that are criminalized or highly stigmatized. Even if you're using pseudonyms, are you describing in your field notes a place or a person in such detail that they could be identified particularly? If you're talking about a tattoo that's very identifiable, just thinking about how that's being maintained. And what are the risks for participants? Fieldwork can be a very intimate engagement. What might happen? What are the potential risks for participants in terms of discomfort or stigma? How will you recruit folks? Thinking about just how that kind of whole process works. And if you are going to be doing interviews, where are they going to take place? Are you going to be in the field doing interviews? Are you going to be in an office? What does all this look like and how does that impact the participant? So just kind of some key takeaways. I went through a lot, I think, quite quickly, but overall, ethnography really gives us this kind of rich form of insights and is important for really placing behaviors and perceptions within their larger context. So it gives us kind of this on-the-ground reality, but zooms out enough to understand what are the factors impacting those lived realities and how people understand and make meaning of those processes. It can be used and is quite useful in public health research, and it can inform interventions. It is well suited for community engaged research, and it can be team-based and rapid. So it doesn't have to look like this traditional form of many years in the field by one person. It certainly can, but it has this ability to be a bit more nimble while still being quite robust. If folks are interested, again, these slides are, I think, going to be made available. Otherwise, I can also send these out. But here are just a couple books that I think are really useful for kind of getting a bit more information about ethnography in general, as well as kind of more rapid ethnographic approaches. And then also some articles that I think are some really important kind of pieces for just kind of understanding what this looks like in practice. And the mayor article, the second one listed, does a great job of also talking about being reflexive and kind of her positionality in the field and what that means and how she navigated it. So I think there's some really great information here. People are keen to learn more. So thank you very much.
That was amazing, Alex. Thank you very much. I do have some questions in the chat. I really appreciated your very thoughtful overview of this complex process. And what I want to do with the questions we've gotten, and we'll do it, I think, a little bit more in our conversation from 12 to 12:30, is to sort of drill into some of the specific hows, like what does this actually look like in your practice? And the first questions I got were about consent. Now, you talked a little bit about the consent process, but I would like to hear a little bit more about, in your project, you're working with people who are actively drug using. So if they're under the influence, I would love to hear how that affects consent. And then also, well, let me let you answer that first, and then I have other consent related questions.
Yeah, I think that's a great question. And consent is super, super important. So if folks are not able to provide consent, even if it's for these informal conversations, like if people are visibly incredibly, under the influence of particular substances, then that's not for me to engage in. Maybe I'm observing kind of what's happening, but I'm not going to try to have a, conversation with folks for research purposes if they're not able to know who I am and kind of what I'm there for. But for people who are able, there are many times I'm with people as they were using substances and they're still able to give proper consent. I think learning that difference, and it can be pretty clear when you're in the field, when people are able to give you that meaningful consent and have that conversation. And I think that ongoing process is really important. Again, in some of my doctoral work, I was hanging out with the same women for over, hours on multiple days, and they did multiple interviews with me. And so always telling them and reminding them that, are you still consenting? You can leave at any time, and if you leave, what does that mean for the data I've already collected? Do you want me to toss it? So having those conversations are really important.
Thank you. So I'm wondering, is there an actual consent form that's filled out?
In the field, I do verbal consent. And so I have a script that I get approved by the IRB. And so it's kind of introducing myself or whomever is kind of in the field. It's introducing the study and kind of what I'll be doing. So I ask, is it okay if I hang out? Is it okay if I maybe jot some notes down? And so it is a verbal piece, just so again, it keeps people anonymous, or maintains their confidentiality rather. So, but all of those scripts go in. And then if I'm doing in-depth interviews, it's a written consent process with, sometimes you can waive their signature if that's the only identifying information, which is what I'm doing in kind of a current study. But yes, there's kind of verbal consent in the field and then written consent for interviews.
Right. I was wondering too about the documentation, because someone's name on a consent form for your study is quite identifying, even if that's the only piece of identification you have. And so I'm imagining that when you work with IRBs, they're used to this kind of research.
Yep. I mean, I haven't had any issues so far with Brown, and in Vancouver, they were very used to that. So yeah, having that kind of waiver of written consent. So I ask it verbally and then I sign, but the participant doesn't need to, because it is the only thing that could identify them. And again, yeah, I study things that are highly criminalized here.
So one more consent question, then I want to ask about analysis. Do you ever consent at the community level or at the site level? How do you get community buy-in to allow you to be there?
Yeah, that's a fantastic question. So we definitely make sure. So for the kind of the example I gave, we don't just pop into these spaces unannounced, like, I'm a researcher, I'm here to understand what's happening. That's a terrible way to do research. So we have community advisory boards. So folks from these organizations, they helped us design the project. Again, some of them are working as part of the team, and we make sure that we're getting an okay and having permission to be there. And again, that's an ongoing thing. So, there was a time where I was in kind of the women's only site. We had been given the okay to go, and a couple people that were using the space weren't comfortable. And so they told the person working, and they told me, and so I left. And so we had to change how we did that site. But so it is this making sure we get permission from the executive directors, and then also getting permission from the folks working at the spaces that day, and knowing that you might, there are days you're going to be turned away, and that's okay. So yeah, it's a multi-level kind of process.
Thank you. So I want to talk a little bit about data analysis. So you've talked about you have a team collecting a lot of data. You're clearly doing it quickly. Rapid is in the title of what you're doing, so findings have to come quickly. So will you talk a little bit about your data management, your data analysis, and how you incorporate the multiple voices in the data that the multiple researchers who are collecting data in the analysis process?
Yeah, so for the kind of this overdose prevention site study, we met weekly. And so we all shared an office. So it's kind of anytime you're coming back from the field, we're having these debriefing kind of sessions a bit more informally. And then we would meet weekly, and all of us would kind of go around and talk about, what were the main themes coming from our field work specifically, like, so what I was seeing, and then in the interviews I had done. And so we were having these ongoing conversations about kind of for each person, what's really coming out. And there were tons of spaces that were overlapping. And so all of that kind of went into having this more iterative approach to doing data collection. So some of these themes would shape questions that we asked because maybe we had overlooked it and we needed to do more of a deeper dive like we did with the police. And then we had a really stellar research coordinator who kind of managed making sure that all of our audio got transcribed and got it kind of all into in vivo. And we did team-based coding. So we did, through these team meetings, we collectively developed initial coding frameworks. Each of us coded the exact same interviews, like we did, I think maybe it was like 5 to start. We each coded the same 5 using that framework. We talked about any discrepancies. And then the framework got iterated on again. And then we did, we had 72 interviews. So each of us were in charge of, 12 interviews or so. And we analyzed or coded those. And then again, we had this ongoing conversation about what we were seeing. So it was a very kind of, it was very much a team-based approach. Our 2 peer researchers were not interested so much in participating in the analysis part. They had been trained on doing it, but they participated in all of our meetings. And so it was that kind of member checking almost of if what we were seeing was accurate, because again, we were all came with a very different kind of perspective. And then when we kind of wrote it up, when we talked about the observations, for some of the gender-based work, we were very upfront about positionality. So I'm a cis woman, and like who was kind of in the spaces. But it was much more of, we were talking about these kind of dynamics that we were all experiencing. We were all seeing some of this violence. We were all seeing the cops being there. And so it did go on to kind of shape the analysis. But for the writing up, because it was also a large team, we didn't have this paragraph for each person about who we are and our positionality. They were much more kind of more applied public health kind of articles than a more long format anthropological article.
That was really helpful. Thank you. I actually have more questions about some of the things you talked about, observation sheets and the environmental scans in your use of your field notes, but we'll talk about that just after 12 o'clock. I have several thank yous in the chat. So thank you very much for your didactic presentation of this. And thank you to everyone who's been with us so far. And I invite you to stay on just past 12 o'clock. We'll come down off the webinar, stop the recording, and continue our conversation a little bit with Alex. So, and we have a setup where you're going to be able to be on